Well, very good. Thanks for that, Jonathan. And why don't we just go into questions and see where it takes us? Anybody want to be the first one?
Hi there.
Hello, Dr. Bricker. My name is Greg Smith, and I am
Greg.
a behavior analysis student here at UNR. I think this is really, really cool stuff. Being able to use this sort of, now widely available technology to reach all of these folks who were previously, in many ways unreachable. My question for you is kind of taking these technologies and delivering more specifically ACT-type interventions to these folks. I wonder, and I just kind of want to get your thoughts on this. Do you think it will be more difficult, and what might be some of the challenges you might face with trying to deliver ACT-type interventions for a wider range of problems, going beyond just like smoking cessation and the quit line? And it's nice that that sort of foundation is already there with these kind of state-run hotlines for quitting.
Right.
Sort of expanding beyond that to a much wider range of psychological problems that folks deal with. Do you think the interventions will be have to be tailored more specifically? Will they be more complex, more time-consuming? Will they have to be more individually tailored based on the psychological problems each individual is facing, rather than just addiction to smoking or maybe some substance? And also sort of, I'd like your general thoughts on that, but also sort of you could tie it to specific ACT-type things like certain ACT exercises or metaphors that might be undoable given this medium of therapy, or some that might even be more facilitated given this sort of a different approach?
That's a great question. Your first name again is Mike?
Greg.
Excuse me, Greg. Thank you, Greg. There's a lot inside your question, so if if there are parts of your questions that I am not addressing, I want to invite you, Greg, to just let me know, so I can kind of cover the waterfront, because it's a wonderful question. And I think the first thing to keep in mind is that there is work being done now, and I think a great example of it is the work by my colleague Yvette Ludman, where they're applying the telephone modality to treat depression. It just happens not to be the specific area that I focus on, but I think the key thing to see is that people are actually doing work in at least in more traditional cognitive behavior therapy, and with some mix of behavioral activation for depression. And then similarly, there's work being done in the area of weight management and exercise. My colleague Jennifer Lovejoy, who actually I'm going to this, attending a workshop today, and she and I are attending together. She is applying this in the Free and Clear program, because they just launched a program last fall to provide a comprehensive weight management program by telephone, in using primarily the ADA, American Diabetes Association recommendations for helping people manage weight. So I think one thing to see to start out is just simply that there are other areas in addition to smoking where people are branching out and they're applying it. And if we just start with how they're applying it, how they're applying the traditional programs, what they are doing is they're simplifying them. And the way I like to describe it is if you could try to communicate something as a therapist as if you were blind, as if all you had was your voice, and so what you do is you are really training your ears to listen very carefully to what the person on the other end of the phone is saying, and trying to pick out the functions of what they are saying just based on the timing of how they say it, the inflection of their words, the pacing of their words. I think sometimes Kelly Wilson refers to the cadences of clients' language. And there actually, I think, in some ways, the phone lends itself to that kind of analysis that we may miss if we're sitting in front of someone where we're attending to the nonverbal cues. And we might have an even greater sense of self-consciousness as therapists, as we are in the room with the client, that we can attend to another modality of communication by limiting ourselves only to being able to listen and being able to speak to our client, to our participant on the other end. And so when there is a tailoring process to be able to simplify this intervention components, it's a tailoring process, and I think a very helpful part of the tailoring process is to pretend as if you were blind, is to close your eyes and deliver what you might normally deliver in person with somebody in a therapy session. The cognitive therapy in traditional cognitive therapy, when that's going to the phone, what they are doing is they're focusing on some very brief Socratic questions. You know, for example, if you're treating anxiety, and by phone, you just might ask certain questions and limit yourself to those questions. How many times have you had a panic attack, and how many times have you thought that you're going to die when you have a panic attack? And you could briefly calculate, well, how many times have you actually died? You could just do a very simple calculation on the phone saying, well, you've thought about it 1,000 times, you've died 0 times, so based on the probability of what's happened in the past, what's the probability the next time you think you're going to die, you will. So someone doesn't have to be in person to understand this idea. You can communicate that with some brief questions by phone, and so a lot of the focus in the traditional cognitive therapy is on what they are saying. Now, and the other thing I think is important to as you think about how is this adaptation made, is each session, each phone call is, since it's so much shorter than a 50-minute session. Phone calls in depression therapy, for example, Yvette Ludman's intervention, it's about 30 minutes. So you're looking at almost half. They are just covering less material. They're looking at a manual, and they're saying, what's the most important thing I want to get across to this client in this session? And I think there's less tailoring to the individual than we would do in ACT. There's less of a functional analysis that is done, so it's more like, this is what you get in session 2, this is what you get in session 3, and we're going to do psycho-ed in session 2, and we're going to do cognitive restructuring in session 3. So it's a little bit more structured, it's a little bit more not tailored necessarily to the individual's particular situation. In ACT, I think there's some interesting ways in which we are, certainly I'm adapting it by phone, and I think ways in which others could adapt it by phone. And I think that the fact that we use so many experiential exercises in ACT, it can make it so useful by phone. A lot of our experiential exercises are with our eyes closed. And this, again, it just lends itself so well to providing a therapy over the telephone, showing a very brief mindfulness exercise with our eyes closed, a selfless context exercise with our eyes closed. Diffusion, I found, was fairly straightforward to do by phone. It was not that difficult to do by phone. I just selected, like the milk exercise, it's very easy to do by phone, and if you're interested I can show you how I do that, but that wasn't that difficult to do. Now, do I do all of the things I would traditionally do in my private practice with my clients, or if I was providing this as a group therapy? No, I don't. For example, when the component of looking at creative hopelessness, that's treated as psychoeducation. I might simply ask someone, what have you tried to quit smoking, and how effective has that been, and what are you seeing from that? So it's much lighter. And then I just simply describe the quicksand metaphor and then ask some key questions. But it's relatively brief because we don't have time to draw out the system in a fairly short intervention. And so that's more psychoeducation. It's much shorter. And so we're not doing everything that we would do in a complete form, but we are doing the core elements when we're delivering ACT. Is that getting at?
Yeah, absolutely. That was a fantastic answer. That covered all the bases that I was wondering, sort of how you would adapt these, these types of interventions through this new medium. And just sort of an interesting little afterthought I had on your last point there. Given that a lot of these are sort of condensed and shortened, it'd be interesting to capture like mediational process data and see, try to capture, very quickly, like you said, the quicksand metaphor, and just kind of going through a few things very quickly, the sort of psycho-ed portion of it. How are the changes on the hypothesized mediational processes there relative to those in a much more sort of prolonged and kind of traditional face-to-face kind of act? It'd be interesting to find that's almost or as effective in a much sort of shortened and condensed format.
Well, there's an interesting side story to that, because as I mentioned in this pilot, one of our aims was to learn whether we could collect real-time mediational data. And we learned an important lesson. We learned that if you want to collect real-time data several times a day, we were collecting it 4 times a day, 7 days a week. If you want to do it, study participants don't like it. They get annoyed by it, and they tend to not be available when you call them, because the idea was we were calling them at random intervals of the day during the waking hours at four pieces of the day between 9 a.m. and 9 p.m. And frankly, we got as you see in the report, we got about half the data we wanted from that. But people were really annoyed, and they didn't like it. And we learned that if we're going to take that approach, the best thing to do is probably shorten it and just do it once a day. So I don't want to discourage anybody from doing real-time data collection. I just think it's going to have to be done in a way that's less cumbersome for the study participants, because getting real-time data for collecting mediators, I think, is much more valuable than filling out an AAQ. That's not to knock the AAQ. The AAQ is a great scale. But the point is simply that if you're asking someone to remember how they responded to a smoking cue, they're not going to remember it if it happened, a day ago or a week ago. If it happened in the last hour, that's something you're going to have much better memory of. So it's just memory is fallible, and so this is a valuable way to learn and really have a much more precise way of teasing out these changes, because they're very subtle. Mediational process analysis is getting at something extremely subtle. And I think that there's a study that we look like it will be funded. We're actually doing a study of ACT planning to do a study of ACT as a group therapy. There's a long story to that of why we're doing group therapy before we do the big telephone therapy trial, which if you're interested I can tell you about. But basically we're going to do a group one, and we'll know for sure in July if NCI is going to fund it. But it looks likely. But we're going to look at mediation. Was the point of mentioning that, is that we're going to look at it. But once again, we're not going to look at it in an intensive way because of the burden it can create for study participants. So we're going to do it at baseline, and we're going to do it at the end of treatment. The other reason why we're not going to do it, which I think is important to keep in mind, is that if you are going to have CBT as your control group, or if you're going to have anything as your control group, you have to be careful not to unintentionally train your study participants to be accepting in the control group. Because the very act of filling out the survey trains people to be more aware of their cues and to learn how to be more open to them, to learn how to be more committed to taking action despite the challenges that are there. And so we were very, very careful about that in our study design, and we put it at baseline, we put it at end of treatment. So there was no potential for bias. So this is an important wrinkle in doing mediation analysis if you're having a control group, is careful about what unintentional training you're providing your study participants, because they may be getting intervention even though that wasn't your intention. The question of whether we will see mediation at the same level as telephone is something we're going to find out. I suspect it's going to be pretty powerful, but the data will tell us for certain. And I'm going to be using the same measures in the smaller trial I've got proposed for the telephone. We're going to use exactly the same measures. We're going to do it at the beginning and the end of treatment, and will allow us to compare how the group did and how the telephone did. And so we'll be able to learn more about that process. But I think that we're on the same page in that conducting mediational analysis is so important, and it really will help us learn so much more about our intervention.
All right, excellent. Thank you very much.
You're welcome.
Hi, Jonathan. My name is Mathieu Villat. I'm postdoc here.
Oh, hello.
Hello. I wanted to ask you about the impact of this type of delivering therapy by phone or internet on therapists. I was wondering how it is perceived by therapists that participated in your study, or if you know about this kind of information from other studies that have been done in CBT, and if you think that it could have an impact in the long term on burnout maybe, or what impact it has also in the, you talked about a bit about that earlier, about the therapeutic relationship also, if it could have some positive effects or maybe negative effects in different domains. So yeah, I would be interested.
It's a great question. I can tell you what we have learned from therapists who are actually delivering phone interventions, and then I can tell you what I think is the implications of that in terms of the costs and the benefits really of taking that approach. What we have learned when the counselors who provide therapy by phone in my study and in prior studies I've done where we're using motivational interviewing, cognitive behavioral skills training, are master's level therapists. One has a master's in psychology and one in social work, and both of them have worked in both individual therapy, group therapy, and telephone therapy, and they like it. They like the telephone. They like the telephone because they feel that they're able to have rapport. They're able to have some therapy relationship with the study participants, and they also feel there's somewhat less of a strain in terms of, if you can conceptualize it as burnout. It's much easier for them from a standpoint of efficiency. It's much easier for them to have the psychological resources to deliver intervention to greater numbers of people, so they could see more people in a session, in a shift by phone. Not just because the sessions are shorter, but because it's less psychologically taxing for them than to deliver their group therapies and their individual therapies. So that's been their experience. They find it's positive, but it comes at a cost. And I think as you're alluding to in your question, it comes at a cost, and the cost is the level of intimacy that you have with the client, or in this case, the study participant. The depth of the therapy relationship is not as great. The ways in which you can use the therapy relationship to help advance client change are much more limited. Especially if you're taking more of a FAP point of view in treatment. There's a lot less self-disclosure in a telephone therapy than there is a therapy, a group therapy, or an individual therapy. And so there's a cost in terms of the quality and the depth and the utility of the therapy relationship for impacting positive change in the clients. There is a cost from the point of view of the therapist, because while it's easier for them, it's less psychologically taxing, they also find it's less meaningful. It doesn't impact them as much in terms of the feeling of making a change in someone's life, because the relationship is not as strong, it's not as deep. And so it's not free. They may find it's greater, in a sense, less psychologically taxing. They are able to help more people than they would in a group therapy or individual therapy, and that certainly gives them a sense of satisfaction and meaning. But it's not free. The cost is that there's less depth in the relationship, and I think that the people going forward, for example, if I think of the quitline model, the people who are usually providing therapy in that context don't have experience so much in providing it in other contexts. So they don't really have a point of reference. This is the way they provide counseling, and a lot of them have mostly bachelor's, some have master's degrees. They have counseling experience, but the majority of their experience comes in providing these therapies by phone. So they have the sense of loss that a therapist who is traditionally a group or individual therapist may have, I think is going to be much less for the people who are providing this therapy by phone. They're not going to have that sense of perspective that you and I might have in shifting these modalities. So in summary, it's a mixed bag. I think that we can reach more people. We can certainly use the relationship to an extent to change behavior. But there's also ways in which we're limited by how we can do that. Does that bear out in the data? That's something we have to see. We have to see that, and we're measuring in our study the Therapy Alliance to learn how much that is predictive of outcome. And we'll see how much that really makes a difference.
Thank you a lot. That's very, very interesting. Thanks.
You're welcome.
Hi, I'm Jessica, clinical student here at UNR. And I wanted to ask.
Hi, Jessica.
I wanted to ask you a question about a population that you mentioned briefly that was impacted by the problem of reach. So homeless populations, particularly. And I wanted to get your opinion. There are some people who might argue that addressing treatment needs in terms of psychotherapy, psychological issues, let's say, is actually going at the problem the wrong way, that in fact we should provide housing first, kind of hit the basic needs parts first, and that then the psychological help should be kind of the second area that we approach next. And like housing first, there's programs called Housing First, for example. I'm sure you've heard of that before. And so what they're saying is this is society's problem in general, that homelessness is a big issue that needs to be addressed societally first, in terms of getting people into homes, and that we'd be in a sense not allocating funds appropriately by paying for treatment needs first. Now I actually I wanted to get your opinion on that. I don't necessarily agree with that, but I also wanted to ask you about disseminating treatments to homeless populations. If we were able to implement treatments in, let's say, shelters, and I was thinking, there are a lot of ACT workshops that have shown to be very effective for many different problems that homeless populations face. If we were to implement that into shelters, do you think, number one, do you think that would improve functioning, quality of life issues? And number two, do you think that might actually eventually lead to getting them out of the current situation that they're in, which is homelessness?
That's a great question. I think there's two levels at which the problem you're talking about is operating, and one is at the organizational level, or you could say a macro level, where the people who are providing services for homeless people, the policymakers who decide how to allocate funds for how to help homeless people, are one key barrier, which are probably getting in the way for you to be able to provide treatment that you want to give these homeless people, and to be able to give them, for example, a workshop or provide some kind of care for them. I would guess, am I guessing correctly, that you're running into organizational barriers to trying to deliver
I'm expecting to eventually.
Okay.
This is something I want to do, but yeah.
Yes. Well, I would imagine, like you say, that will be a problem. And the first thought that comes to mind is creative hopelessness. To really help. I think the intervention at first is going to be on the organization, not on the homeless people in themselves. That is, if there is an organization that you're trying to get to, or it's really helping them see how effective has this approach been. Has this really addressed the problems of that homeless people face? Are they really able to function any better in society as a result of putting this rigid focus just on their housing needs? Where has that really got us? It clearly has helped us somewhat, but there are tremendous limitations to that. And if we just keep doing the same thing, we're going to keep getting the same outcome. And they may be screaming to the feds to get more money to provide better housing, but until that happens, we have to do something else and provide some kind of auxiliary or complementary service. So I think part of getting at the issue is, if you're thinking about it from an ACT perspective, is I think creative hopelessness is a useful construct for conceptualizing the change of the organization. And then is the level of how do you help the actual homeless people themselves. I have faith that they can benefit from an ACT intervention just as well as someone who is not homeless. I think that our own thoughts and the people who are providing housing programs, the policymakers, their own thoughts about homeless people not being capable or not being able to understand or engage in psychotherapy, those are the things that are getting in the way of homeless people being able to engage in treatment. How you deliver that is probably going to have to be very different. An hourly psychotherapy session at a clinic is not going to work very well, but that doesn't mean it won't. I'll give you an example. Laura Brown in Seattle, she's a feminist psychotherapist who's focused a lot on trauma. She has developed the Fremont Low-Fee Therapy Clinic in the Fremont neighborhood of Seattle. It's the only clinic for low-income populations, and a large percentage of her clients that come to her clinic are homeless. And my wife runs DBT groups in that program, and some of her members are homeless, and they're coming in. In fact, her program is tonight. It's at 6 o'clock on Wednesday, and they come in for treatment. So there are going to be some challenges to them showing up. They may not show up at the same rate. Hers don't show up necessarily at the same rate or have the highest attendance, but they can benefit. I think the other thing to see is that homeless people is a broad spectrum of individuals. Some of them have severe psychiatric disorders. Some of them are less severe. Some of them, it's more of an economics problem. They've maybe had a job loss, they were laid off. Some of them, they may be more chronically homeless, and some more temporary. Some of them are going to be more or less educated, and then there's going to be variations in levels of substance abuse. So it's a heterogeneous group of people. And so I think that a core process model can be useful at getting at a broad group of people. But I think it's also important to keep in mind how you're going to tailor the programs to them. I think a workshop is a nice way of beginning, of being able to see initial reactions, initial responses to this. In terms of testing the treatment, if you're working with a homeless population, there are going to be limitations on collecting follow-up data. So you're going to probably want to get now I'm thinking more like the researcher, how you're going to collect this data. We had some homeless folks in our study, in the telephone study, and we just had to get a lot of phone numbers of relatives and friends, and then to keep in mind that they're probably going to use cell phones with a Visa card, and then it'll expire and it'll change. So being very persistent with them will be key. As far as when you collect your outcome data once they show up. But I think it's a good way to get a gauge of how they're responding. But I would be shocked that they wouldn't benefit from an ACT workshop. Why not? I just can't see what is it. the way ACT can be provided, that could be so complicated that someone who's almost wouldn't understand it or make use of it. But I think your first barrier is probably going to be helping get over the control agenda of the organizations that serve homeless people.
Thank you very much. That was very helpful.
Okay.
Hi, Jonathan. I'm Tom Sabo. I'm a fourth-year student in the Behavior Analysis program.
Hi, Tom.
Hey. I'm going to bridge the last two questions that both had issues at the macro level with a need that you mentioned earlier for program evaluations to measure maintenance and of effect. I work with provider organizations who provide care for people with intellectual disabilities, and the folks who are caregivers in these kinds of fields, they often tend to think that they tend to display towards us a kind of machismo, like we're therapists too. We don't suffer from burnout. We know how to handle our emotions, and yet we all suffer quite a bit, particularly in work in caregiving. So I'm wondering, what kind of program evaluation studies can we do to look at long-term effectiveness of some of this work?
Well, it's a good question. I think that, I see a couple questions inside your question. One is the issue of if you are trying to do an evaluation of burnout in therapists who provide care for people with developmental disabilities, I think that the first thing is to make the case to the organization that you think this is an important problem to be examined. I'm assuming that this is not what they're doing now, that they're not providing program evaluations, and so you see the need. Is that correct? Yes. So what I would do is if what you are seeing is that need, is again working at the organizational level first, just to ask them how it is for them to be providing this therapy. That is, how are the therapists doing without any suggestion that you think they are burned out, because they clearly have a fusion to this concept of burnout that isn't working for them. And so if the idea that we think they may be, they don't think they are, but that we may think they are. And so I think if it can be posed in a neutral way, that may be a way to get at, to get your foot in the door, if you will, to begin to understand them and to learn about, maybe even focus it on the clients and say, we just want to learn about what kind of, survey you about what kind of services you provide the clients and what kind of treatment programs you're providing, what kind of counseling you individually are providing. And we just want to learn about how they've been receptive to that and what your perceptions are about the clients. And so if it's framed in a more neutral way, you can honestly collect data about program evaluation without them feeling threatened by your wanting to come in as the researcher and collect data. My hunch tells me that the fact that they have such a strong reaction to you and to the suggestion that they may be burned out, if I'm reading your question accurately, suggests to me that they may be burned out, that maybe this is an area that's very sensitive for them, and that it may not be as simple as, we have our treatments, we know what we're doing, thank you very much, we don't need you to come in and show us anything or test anything or evaluate anything, we're doing fine. I think the more they're digging in their heels, the more there's something there, and I think if there's a way you can come in on a softer approach, in a way to show them that it's more neutral. We just want to learn about what they're providing, how that's going for them, or how the clients are reacting to that, how they are experiencing that, and that may be a way to get at it. Now, as a follow-up, Tom, are you thinking of maybe implementing some type of RFT-based therapy or behavior analytic therapy into these programs? Because I gather that's not what they're doing now.
They are doing it with our support, and yeah, we definitely are involved in that.
Okay,
and
that's
I
good.
think that, interestingly, it's not the frontline folks that have the most, who display the most fusion. It's the folks who are higher up, the leaderships of the organizations who tend to demonstrate that kind of fusion. But those are, and I think what you're suggesting is kind of cool. Just ask them how it's going. That might be effective.
You know, since you just said that, it's the higher ups. A thought just came into my mind that I think it would be really, really helpful if you could survey both the leadership and the frontline folks, because it sounds like there's a disparity in what each are perceiving. And if you can ask the same questions that interest you and compare them, I think that would be nice objective data to show the leadership that maybe they're out of touch, that maybe they don't seem to be really getting what the experience is of the frontline folks who are providing therapy, and this is a way for them to sensitize them to that. And the data don't lie. The data will show them. If your intuition, your scientific mind is telling you these guys are the ones that are really the problem, then maybe there's a real disparity. And I think that's going to be a very powerful way for the program evaluation to lead to some real organizational change.
It's a really cool idea. I'm probably going to go about it just that way. Thank you. Thanks.
You're welcome.
Hi, Dr. Bricker. My name is Donnie Newsom. I'm a student in the behavior analysis program here.
Hi, Donnie.
I wanted to go back to something that you had mentioned in your presentation earlier, that you had encountered some critics around the fact that biochemical validation isn't real accessible in the distance therapy modality. I was wondering what you see on the horizon in terms of how you can respond to those kinds of criticisms. As someone from the behavior analysis camp, I'm very skeptical of things that are based just on self-report as well. But it seems like there could be some solutions. I wonder if you how much thought you put into that.
Yeah, well, it's a great question, and it's an issue that is ongoing, and the challenge that you are highlighting is if you are trying to collect data on a behavior, in this case smoking cessation, but it could be alcohol or something else, you want to know if the data is valid, and biochemical validation is one way to go about learning whether it's valid. I don't think it's the only way, but it's one way to learn about it. And if you're doing that by mail, or you're doing it by a phone survey, if someone is 100 miles from the university, it's not practical to ask them to come into the clinic to blow into a device to verify that they haven't smoked. And so you have to do something else. And the solutions that we've come up with are the following. One is we do a mailed survey collection where they provide a swab, a buccal cell swab, in the mouth, and then they put that in a little pouch, and then it's postage paid, mailed back to a lab. Actually, it goes directly to a lab independent of the cancer center, where they will analyze that for cotinine, and if it is above 15 nanometers, I believe, is the measure of cotinine, then it's considered a smoking unit. If not, then they aren't. But there's problems with that. One is you don't really know that was the person who provided you the sample. You can't verify it. You could have your non-smoking spouse or friend or someone else provide the saliva. And the other is in the other direction, is that you may be exposed to smokers in your home. So even though you've quit, your spouse still smokes, and so you could come up as basically someone who is a false positive. You said you're not smoking and you're being truthful, but because of the exposure in your body, it ends up showing the other direction. So this is a limitation actually of even if you came in the lab and you provided the swab. And so it's not just limited to the mail. The good thing about mailed saliva cotinine is that it keeps. It can, if you put it in this little container, it can keep for actually a couple years. For a genetic analysis, I should say, it keeps for a couple years. For a salivary analysis, it's a couple weeks. And so there's, it's very practical means to do it. We're going to do it on a random sample of people. We're not going to do it on everybody because it's cost prohibitive. But it will allow us to provide an over or an under reporting. The thing to see is that when you look at the data for smoking, the discrepancies between self-report and carbon monoxide or cotinine are actually quite small. They're usually around 2 to 3% at most. And so the level of over-reporting and the level of under-reporting, so it's plus or minus 3%, is really low. So it could be that the fact you had it made people more honest, knowing that they were going to get it. So another solution is David Murray. He's an epidemiologist at Ohio State. He came up with what he called the bogus pipeline procedure. It's actually a social psychologist who evolved into an epidemiologist. But anyway, he did the bogus pipeline. The bogus pipeline is basically saying, we are going to collect cotton swab data from all of you. You're going to put it in this package, and we're just going to use it just to help confirm, what you're telling us, and that's all. And then they actually don't analyze it at all. So there's a social expectation created that you will be tested, and so he found that increases accuracy rates. So there's some different ways you can go about doing it. In my analysis, like in the group study we're doing, we're going to do both. We're going to have self-report only, and we're going to have confirmed, and we're going to compare them. Because actually the jury is still out, and the SR&T subcommittee on biochemical validation, has guidelines, but there's nothing for certain. So we're going to report both in the study, and we're going to look at discrepancy rates. And for those who trust the self-report, they will be satisfied, and for those who feel like, well, we really need to see them confirm, they will be satisfied as well. So that's the way we've been going about the issue.
You can almost see how just the accountability that comes with even the fake biochemical validation measure is almost treatment in itself. Just to have someone monitoring it, I could see having some effects. I suppose the real trick would be figuring out how to surreptitiously collect the biochemical validation, so you can really see the other side of how accurate the self-report is in the absence of the impression that they're actually being validated. But I'm not sure how you would do that, particularly through the phone.
Well, that's a cool idea. I mean, maybe you could say it's for another purpose. We're going to collect. Collect data just looking at some genes, or we want to learn about some properties of saliva for a second study we're doing, and you might do some slight deception, but then afterwards you debrief them. But yeah, that's a really cool notion of how you could get at the effect of this expectation that you will be measured. We could it'd be interesting to look at different ways you could tease that apart.
Thanks so much.
You're welcome.
Hi, Dr. Bricker. My name's Emily, and I'm a student in the behavior analysis program.
Hi, Emily.
And one of the things that I was wondering about as I was reading these articles is how this type of modality in terms of providing treatment via the internet or text or the phone will impact triage for clients, especially when you have kind of severe, what we would label as severe depressed clients doing very, very well via text messages, and how that would kind of impact the treatment of them and where we would refer them to in terms of professional, highly educated individuals, or just kind of telephone, internet, email type things.
Yeah, so it's interestingly, the assumption that the public health researchers have made is that if you want to help someone with mild depression, or you want to help someone who is a infrequent smoker, the best thing you could do is you provide them a low-level intervention. You provide them an internet intervention, or you provide them a phone intervention, or you even give them a pamphlet or a guidebook to how to quit smoking. And then the assumption is that if you are depressed, or say you're a pack-a-day smoker, that you're going to need something more intense. So we would recommend then we try to get that person in a clinic to provide a full treatment, a group therapy, an individual therapy, and what they do, if it's smoking and depression, they might sequence it. They might say, well, we'll start with the depression first, that's more important, then we'll do the smoking, which has its own pitfalls that we can chat about. But the data, as you see in the Kessler study, is suggesting that notion of giving a low-level intervention to people who have the lower levels of pathology, of symptoms, may not be that helpful, and may be a very flawed assumption, because actually those are the people that benefited the most. Who would have guessed? Similarly, in data that I'll be presenting at SBM tomorrow, I'm going to be showing that people who actually smoke more did much better in the treatment. We just finished a large randomized trial of adolescent smokers. We provided cognitive behavior therapy and motivational interviewing to 1,000 adolescents who in their senior year, and when we did overall, the intervention was almost effective. It was 0.06 among all the study participants, and study participants had to smoke at least monthly. If you're interested, this is published in the October issue of the Journal of the National Cancer Institute. But it was the people who smoked daily, or more, who actually did the best. We doubled quit rates in those folks, and they were the ones who were who were getting the telephone counseling and did the best. The type of study that I think would get at most directly to your question is to take a stepped care model, and where you basically have three groups of people who smoke less, or less depressed, and moderately depressed, and highly depressed, or if it's smoking, we split it up that way. And then you randomize each of the groups to either an intensive intervention or a less intensive intervention, like a phone therapy or internet therapy. And then you look and see within each of those three cells which treatments seem to work the best. Because what I'm describing to you is a comparison. The Kessler study is comparison with usual care. The study I just described that we completed is a comparison to a proactive telephone counseling versus no treatment. And so the comparison group, it would have to be the group, the more intensive therapies that we are used to doing. And so we would be able to empirically know that. But I think all of the assumptions we have, I suspect, are wrong about what is the best treatment to match and in terms of intensity. And I think that over the next decade, there'll be some surprises about what these phone therapies can do with someone who doesn't have very much education. I think there are a number of things that people with less clinical education can provide, and that we, as psychologists, behavior analysts, who have a PhD level training, doctor level training, are going to be more in the positions of supervising, training the individuals providing therapy. Will be more about developing these treatments, testing these treatments, doing randomized trials, doing program evaluations, which I actually think is an excellent use of our expertise. And I think that the people with less education, with bachelor's degrees, master's degrees, can be trained in doing this. Edna Foa trained master's level counselors to provide trauma therapy using her exposure and response prevention treatment program, and actually did better than the PhD level therapists. And so I think that the model is shifting in terms of not only what's cost effective, but also in terms of I think a more efficient division of labor where our expertise can be better put to use, and we can also respond to the shortage of mental health care. If you look at the job growth rates in the next 10 years, what are the areas in which jobs are needed? Healthcare is a major one, and providing psychological care is a part of that. And so to meet that need, I think having more counselors available is very useful. And so there's certainly many more people who have master's degrees and bachelor's degrees in counseling and psychology and allied disciplines than there are with PhDs. And so they're going to fill an important economic need as well.
Thank you very much.
You're welcome. Yep.
Hi, I'm Greg Govan.
Greg, I think we met in November.
We did, yes.
Yes.
It's great to see you again. You've basically been well. You've answered many of the questions I wanted to ask, and so thank you. So
You're welcome.
The question I'm interested in right now is that how can ACT address dropout or treatment refusal in terms of like a public health model right now? Yeah, I'll just stop there.
Sure. I think that ACT can be very helpful, especially, I think there are two processes of ACT that can be very helpful. And the first is values, and the other is creative hopelessness. There's been a theme I see in the questions, and the theme of particularly like the questions about organizational barriers, where I see that creative hopelessness can be so useful. Before I get into the specifics of how I think ACT could be useful specifically for people who are dropouts or refusers of treatment, I think that there's a very practical matter, and that is even being able to reach the people who've decided to refuse, the people who've dropped out. And the way you reach them will depend on the context in which they have refused and dropped out. If they have dropped out of a study, that's different than if they've dropped out of a clinical treatment program. In a study, you have limitations on the protecting the rights of the study participants, so you're not harassing them, and you're not restricting their personal freedom to choose not to have treatment, because that's something that we as ACT therapists, clinicians, and researchers have to respect. We have to make room for that they may not want any treatment at all, and I think that's part of our challenge. And so there'll be restrictions on what you can do. If a study was designed that was meant specifically to address dropout, then you've got a lot more flexibility to contact them. In a clinical setting, you have a lot of flexibility, and I think starting just in a nuts and bolts concrete sense, a phone call is a very helpful way of re-engaging with someone who has left treatment, who has refused or has dropped out of treatment. I think that dropout, there are a lot of reasons for what we call dropout, and I think we have to be careful about how we conceptualize the dropout. Some people who appear to be dropouts are simply people for whom other values in their lives have taken a higher priority. It might be childcare, it might be a job loss, it might be moving, it might be a cancer illness. We were very persistent. I use the two words tenacious and gracious. Our people who are our phone counselors, people who are our data trackers, are tenacious and gracious. And so we never assume that they are refusing until the study participant tells us that they don't want to be in this study. We assume that there's something else that we just haven't discovered yet, and we want to find out what that is. So we call them at different times of day, again within IRB approval, different days of the week. We try relatives, we try different phone numbers, we mail letters, personalized letters that we handwrite and we hand sign. Nothing machine signed, nothing written on the envelope that is not handwritten. So we make a personal connection to them. We're showing to them we have compassion toward them. We care about them. We genuinely want them to participate, and we want to be useful and helpful to them. And if you can communicate to them in whatever means you have, if that's all you've got is a phone call or a mailed letter, mailed letters are a lost art. Everybody uses email now, and they use text messaging, and I think they're a barrier to some, especially at this critical juncture. As much as I'm an advocate for the public health approach and using the internet, let's not forget the U.S. mail is a great way to reach out to someone. Marcia always makes this case at the end of her talks, where she talks about suicide, and she says, the only study that's really shown to help prevent suicide is the one where a physician mailed letters to people and just checking in and seeing how you're doing. And so it was a very humbling, simple public health approach that just showed you how you can reach someone. And so on the technical side, I would make use of the phone to a personal. Really, it's a way by phone or by mail to put your hand on someone's shoulder and show them that you care about them, and that can turn things around. Even for someone who said, "I don't want to have anything to do with you guys, get away from me," you can turn them around in a very gentle and quick way. In terms of ACT specifically, I think the values are key. What would being in this, what was being in this study about for you? I noticed you dropped out. You told me you don't want to be in it. Well, let's go back. Let's rewind the tape. What was it like in the beginning? What was it that drew you here in the first place? To kind of help them get back to what were the basic values that drove them to come here to enroll in the study. Something was leaving them. It wasn't their wife telling them to go get help. It was something else. It was something more fundamental, something more basic inside them that led them. So whether your treatment is a CBT treatment or they were going in for a 12-step treatment and the values was never referred to, you could still use values. You could still tack on ACT at the end in a one-session treatment refuser intervention to get them back into whatever they're trying to do, 12-step, whatever it is they were doing. And I think that's a way to kind of help them touch that part of themselves which drew them to do this study or enroll in treatment in the first place. I think the other side is creative hopelessness. How well is this working for you? I see you dropped out of the treatment, or that you don't want treatment anymore. I mean, how did that work for you? I'm coming from a place of compassion. Are you willing to share with me, how things are going for you right now and how that's working out, to help them make the connection between what they've chosen to do and what's happened.
Thank you. That's great.
You're welcome.
Hi, Jonathan.
Hey, Steve.
A series of questions around kind of the larger context for the direction you're going in and trying to think of this in a public health way. One is as I think about the range of problems to which this approach might be relevant, I'm wondering, can we find ways to make it even less connected to professionals and more connected to the culture itself, in terms of self-help groups or churches or communities themselves or the media and so forth? It seems like some of the processes that we know about, if you think about the ACT model as being more important, just as a way of summarizing some of these transdiagnostic processes that are that are critical, and there's others out there, but this is a good place to start. These are things that you can put into schools, child development, I think. And so my first question, there's a few I want to ask, is in a lot of these problems where we're trying to do preventative work, but also find ways of reaching people in a very efficient way, do you have any thoughts about ways that we can get the professional, even to the point of what you're doing, of the phone calls for 90 minutes, even less part of the picture, and other kinds of existing mechanisms or processes in the society harnessed to producing more psychologically flexible people who can respond to the life challenges?
Yeah, so I think actually the most effective way of getting these basic processes, these ACT processes out there to society are by us as psychologists to get out of the way. And I actually think that we ultimately probably won't be the ones who will be able to reach something at a societal level. I think we can be the engines of that process in terms of getting the people who can have a much broader reach than we can to be able to disseminate it, to provide it. And let me tell you what I mean by that. I think, for example, if you look at organizations, if you're trying to change organizational culture so you get your employees to be more flexible, to live according more to their values, I think the presidents of those organizations, the leadership inside the organizations are going to be the key. Those people are most likely not psychologists. The president of the Cancer Center, Lee Hardwell, who's a Nobel laureate, is a basic scientist. He studies yeast cells, and he learned how yeast cells divide, which provided a very important model for understanding how cancer cells divide. And he is a Buddhist. And I gave a talk 2 years ago at the Hutch. I just put out there, if anybody wants to chat about mindfulness, we were having a retreat. And he came to that. And the point I'm making is that he got very engaged in this, and he's now very interested in how we can begin to at least change some things at the Hutchinson Center so that people are doing things more flexibly, and there's a greater sense of meaning and purpose that maps on well with values. Coming from him, it's a lot more persuasive, has a lot more penetration than coming from me, assistant professor, one of the many people at the Hutchinson Center. To have it come from him than from me is much more powerful. So I think that one of the vehicles of change will have to come from some people who are not us, in a sense, who are not psychologists. The schools are an interesting idea. I actually think, I know your work they're doing with Jackie in freshmen at the University of Nevada Reno. I think elementary schools can be a really interesting direction to go, where sometimes my clients, my practice will say to me, why didn't anybody teach this to me when I was young? And so to be able to have teachers in the elementary school level, the primary school, first to third grade, provide a very basic training in mindfulness. And actually my niece, she goes to a private school in Colorado, she's actually learning about meditation now in her class. I didn't say anything to the teacher. They just got this idea and they started doing it. And children can meditate, and so this can be a very basic part of my niece's life, and a very basic psychological skill she can carry with her throughout the rest of her life, and I believe can prevent a sequelae of mental health problems and many other problems. There's another outlet. So there's the school, there's organizations. I also think the media can be very helpful. And I think we, as psychologists, particularly who follow an analytic perspective, contextual behavioral scientific perspective, can work with marketers. Marketers are always trying to find a way to change behavior, and maybe we could help give them a conscience by helping change behavior that really could be in the service of individuals' values. Other types of media, I think, are the news media. We in the CBS community, in our work, are talking to the media, and we're talking to the media and describing what we do. I talked, for example, there was an APA press release I did a couple months ago on fear of flying. A hobby area of research of mine is the anxiety of flying. And it was just a very practical piece on, what sorts of tips would you share with someone on how to help them alleviate their fears. And of course, I kind of answer the question is it's not about alleviating them, it's making room for them. So even in the question, there's an assumption that we have to control. So part of it is how you respond to the reporter, and the basic point is that my message got across, and now it's being able to reach a Men's Health journal or some magazine. And so people, as they begin to read about it in news media, that will be another seed of change. That'll be another way to be able to penetrate at a broader societal level is our use of the media. Now the challenge of that, whether it's an organization, whether it's a school, or the media in its various forms, whether it's advertising or journalism, is in how we, as contextual behavioral scientists, translate what we're doing so the public understands and non-psychologists understand what we're saying. So getting away from our technical language, which works in our world, in our environment, within the walls that we live in, that works because we need the technical language so we know precisely what we're saying to each other. This is true of every field. Any field has their own technical language. But when we're speaking to people who don't share that language, who don't understand it and who aren't trained in it, our job is to translate it into a language they understand. I think the work that Russ Harris has done in that regard, the ACT Made Simple, the Happiness Trap, are a nice example of how to be able to translate these concepts, and to do so in a way that is faithful to the model. So that is important as well. So we want to make sure our translations fit the model and they're not misunderstood. So maybe some back translation. Which actually gives me the idea that we could do a study to look at, presenting an idea to non-psychologists, and then, in a sense, translating back to us what they heard and seeing if we're getting across our message. And that could be a neat way of learning whether our communication is working. But I think the kind of the core inside all of this, the hub inside all of these different ways we can reach the public is translation. And ultimately, us not being in the picture. I think our best role is behind the scenes, and I think that's where we're going to make the most impact.
Yeah, I agree with that. A kind of related thought, which is the way that we've organized ourselves professionally is so much by problem area, and in the area of mental health, often by syndromes and so forth. But yet, if you look at what's happening in the ACT literature, you have such a powerful indication that these common core processes, modified in terms of the specifics at a topographical level, but at the level of function, probably not that much modification, seem to account for a lot of different kinds of phenomena. Inside smoking, it's not any one thing, just smoke, in terms of the specific functions for a specific smoker, but you're going to find the relevance of these concepts like experiential avoidance that then might show up over in depression, or might show up over in problems in dealing with work. And I'm wondering, in terms of trying to apply a public health model to it, if we could find ways to overcome some of the kind of balkanization and silo-like mentality that is built into the healthcare delivery system and the way it's organized around specialties and professions, especially in the behavioral health side. Would there be let me ask it this way. It's been my experience, if I can touch somebody with an ACT model about a particular problem, it's a lot easier to deal with another problem using the same model. I don't have good data on that. It's just that I almost cannot think of an exception of that with clients. If we can make progress on depression, they've got relationship problems, I can make progress there too. And by kind of taking some of these same processes, moving them over, and trying to help them see that there's some generalization that's possible there. I see it even in your answers, because you're saying, you got problems with dropout or something, look at some of the processes in the organizations in yourself, etc. You're sort of moving these things around in terms of the essential. So could we do something like this? And it's on this theme of what we can afford and what society needs. When people come in for smoking, let's say, that the people who improve, that we're also mindful of, well, what are the other problems they've got? How about the ones who are depressed? If they moved on smoking with your 90-minute ACT intervention, my guess is you could move them on depression a lot faster by leveraging the progress that they've already made, because you could take the same processes and target it. It sort of takes advantage of what's inside the ACT work, of the same model working over and over again. I guess the broader question, though, is just to ask, and there's a practicality issue in here, of how to make these things efficient and economically sensible, and not just funded by grants, but situated inside healthcare delivery and so forth. Do you see any ways that we can kind of think about our role in a different way and get us out of the way, but kind of leveraging these empirically supported processes and procedures into interventions that have broad impact or that can be replicated quickly to the many areas of life and life's difficulties that people might face that are of human and quality of life and economic cost to them and the family and society and organizations and so forth. Do you understand the question that I'm asking? And it's not very well stated, but...
Well, let me try and answer, and you can tell me if it seems like I've understood it. I think that there really, at one level, there is the problem of core process leading to a variety of outcomes that on the surface look different, but functionally are the same. And trying to see how that is really at odds or differs so sharply from the medical model that we have developed over the last 70 years that treats these disorders as separate entities. When you and I know the levels of comorbidity are so high, and you and I know that these distinctions are artificial and that they are invented because they have been adopted from a physical model of disease and transplanted into a world of the world of the psychological experience, which cannot be split in these cut and dry ways. So, how are you able to deal with this problem, especially as the DSM-4 is going to become the DSM-5, and we have now even more diagnoses are going to be added, and we're having a revision of some, and then we're eliminating others. And so the diagnostic machine continues to run, and I don't know that we can stop it. I think it will continue to run because that has been the culture of medical care. But I think there's a way to go around it. And I think one way to go around it is to look at these novel modes of delivery of mental health care. And in particular, if I take the example again of the quit lines, people who run quit lines are not married to the medical model. They don't think that way. They think in terms of how can we help people change behavior in a way that is cost effective. They don't have the same territorial issues that other disciplines may have, and so they don't feel threatened by the idea that you can take a treatment that goes after a process and changes it. They care about outcome. They don't care about process. I can tell you that. I mean, I talk to my colleagues in public health, and I love talking about mediational models. I just got a paper accepted in Psychology of Addictive Behaviors, mediational models. I love mediational models. I can talk about them all day. They don't really care about that, but they can dig that I'm into that, and what they care about is the outcome. Well, where we're on the same page is that our outcomes, we're going to reach the same place. We're going to reach it through a different mechanism, and our hope is we're going to improve it. They also don't feel wedded to the idea that if you have smoking and you have depression, you have anxiety, that you have to treat them as if they are separate entities, because they're not invested in the whole enterprise of diagnosis as it has been conceptualized and developed over the last 70 years. And so they are our allies. And in fact, as I alluded to earlier, if you look at the Klesky article, and as I was talking about in my talk, you look at the re-aim model, their focus is on quality of life. It's a large focus of what they're doing. They're not so interested in, is the person not depressed, is the person not anxious, the person, I mean, they care about those things, but they put equal weight on quality of life. And they're as frustrated as we are when they say, you know, when they see policymakers or others who say, well, you know, let's see, you know, quality of life is not so important. But the public health folks, you know, they can be our allies, and they have influence. They're able to reach a large number of people who are suffering. And so I think one solution to the problem, rather than trying to fight it or change it or criticize it or judge it or, you know, apply all the things that, you know, we may feel are our knee-jerk reaction to separate ourselves from it, is to go around it. And I think that's one possible solution. The other solution is to be open to it and to always include it as part of our outcome measures, but to be able to do the studies that take people with high levels of comorbidity, people with multiple problems, polysubstance abusers, people with who are dual diagnosed, provide them ACT and show that through changing a core process, you're actually going to get multiple outcomes. Because I want to go a step further from what you said. You said, Steve, you know, what if we change this process to get them to quit smoking? And that would make it easier for us to then, you know, change that process again to help them, say, with their depression or anxiety. I would like to be as bold as to suggest that maybe we could just do one intervention where we're changing the core process, and then we end up, as an outcome, lowering the depression, lowering the anxiety, lowering the smoking. In the group study I mentioned earlier, I've got measures of panic, generalized anxiety disorder, of depression. We've got a measure of PTSD, and also body mass index behavior. And it's an interesting thing for me because as a secondary outcome, I'm going to be looking at whether an intervention that was focused on smoking will say nothing about depression, will say nothing about anxiety, if it actually moves those processes in such a way that they are less anxious and depressed, without having to do anything extra, without having to do any follow-ups, intervention, and the data will tell me if that's the case. But I think part of the way for us to build maybe better fences, or I should say maybe open ourselves and become better neighbors to our colleagues who are conceptualizing the world from a diagnostic point of view, is to show them the data. And the data can be very convincing. And I think that's a way to help create at least an embracing of both sides and some change in the way we diagnose now. And I think the other way is to just go around it and work with people in public health who don't feel so invested in this topic.
That's a neat answer. Thanks. We've taken a lot of your time, Jonathan. Is there anything that you didn't get a chance to say before we wrap it up? Or if I'm sensing the time right, we're probably about time.
I would just say I'm grateful to have the opportunity to do this. I think the setup, the structure of this class is really cool, and the whole idea that I can be 1,200 miles away at a conference and Skyping is just the coolest thing. And it's just the public health approach to teaching.
So yeah, we're trying to leverage that, follow the same kind of message in what you were talking about, even the process that we're following here today. But
and I'm open to continuing the dialogue and having contact with those interested in exploring this approach and how it might be applied, the public health approach might be applied. So even after this time together, I'm very open to that.
Why don't we just end it there? Thanks a lot for that, Jonathan. You've given us a lot to think about, and appreciate the expertise that you brought to it. It was wonderful. Thank you.
You're so welcome. Thank you very much.